And there's definitely a subset of people that have, quote, interstitial cystitis when I think they have pudendal neuralgia.
Same with vulvodynia and urethral syndrome. There seems to be theories
Absolutely.
around that.
Oh, I think those things are often pudendal neuralgia. So pudendal neuralgia is irritation of the pudendal nerve, which is a nerve that is innervated from the second, third, and fourth sacral nerve root on either side. And the nerve comes off of those roots, which also the second sacral nerve root also starts to form the sciatic nerve, which is going down the leg. And then it gives off a little branch, and the third and fourth nerve roots give off small branches, and they form the pudendal nerve. And so the pudendal nerve is a somatic nerve. It has some effect of contraction of the pelvic floor, or branches of it do. It also provides you skin sensation around your anus and on your vulva, the labia, and then up to the clitoris as well. And so the path of the pudendal nerve is a tortuous and defective path that was designed poorly or evolved poorly. And it actually goes down the pelvis, and it goes between the sacrospinous and the sacrotuberous ligaments, which are two thick ligaments that connect our sacrum to the side of our pelvis. And for some dumb reason, this very important nerve goes right between them, like a little crusher sandwich there. And as long as you have plenty of fat in there and you have plenty of kind of space, it doesn't seem to cause a problem. But in a subset of people, that space is really narrow, and they get pain there when they sit, and they will crush the nerve. Now, this is only one version of pudendal neuralgia, but this is the most common one, where classically the horseback enthusiast or the chronic bicyclist has been like compressing this nerve for so long that eventually they've caused the nerve to be inflamed. And so about 85% of pudendal nerve entrapment cases are at that ligament right there.
Okay.
It's probably some combination of behavior, like riding a bike a lot, and then a predisposition, an anatomical predisposition. So people that have that kind of pudendal neuralgia will have pain when they sit. Sometimes it can be really bad pain to where they don't even sit, or they sit on a cushion all the time. They have pain. They'll have pain in their coccyx. They'll have pain in their rectum. They may have pain in their clitoris or their vagina. And then men get this also. So they have penile pain and sometimes sensory loss in their penis. They still can get an erection, but they don't feel as normally as they should.
Okay.
And there's a variety of sexual dysfunctions that can occur. And there are other kinds of pudendal neuralgia that are not structurally caused by compression there, and they're probably caused by inflammation, like endometriosis. Inflaming that area can cause pudendal neuralgia also. It's a very difficult condition to treat. Like I was telling you about, like how chronic colonized bladder UTI is something that not a lot of people want to deal with, and that they don't know how to deal with it. Not a lot of people want to deal with pudendal neuralgia either, because we're not very good at treating it. Like I know a lot about it. I think I understand it better than most doctors do, but there's still only so many things we can do about it, and sometimes we're not really that effective. You can do pudendal blocks, where you block the pudendal nerve with local anesthetics. That will lead to temporary relief. In some people, it leads to longer term relief, but in general, it's more diagnostic in nature. We can put steroids around the pudendal nerve, which does help in some people. We can put Botox around the pudendal nerve, which I think does help quite a bit, actually. And that's probably my number one thing, because it's relatively inexpensive. It's relatively non-invasive. Doesn't cause a lot of problems.
How long do those last? Those like nerve blocks or Botox?
Well, nerve blocks only last for a matter of hours, really.
Okay.
In some cases, they can seem to work for like weeks. If you have a nerve that's really, really inflamed and it's just constantly firing by some mechanism that we don't understand, and there's lots of stuff here that we don't understand, but by some mechanism, if you can like block the nerve for 6 hours, which is chemically kind of just turning that electricity off, what it does is it just totally depolarizes the nerve. Like it opens up all the channels. So all that chemical signaling just leaks out more or less, and the nerve basically becomes dysfunctional in a good way. Like it just gets put to sleep. It just doesn't work anymore until that local anesthetic is consumed and wears off. The nerve is just broken, And so you get profoundly numb. And you know, as you go to the dentist, like you get a block in your mouth, you can get your tooth drilled on, it doesn't hurt. So it's the same thing. So if you're blocking the pudendal nerve, you'll get temporary anesthesia. But if you have a nerve that's really, really inflamed and you block it for 6 or 8 hours, there seems to be, at least in some people, a longer term effect where you're almost like hitting the reset switch, or you're rebooting the computer on the nerve. And when it wakes up again, it's not quite as irritated. But it doesn't work in everybody. But I have seen some people that claim that the block lasts for months, and I don't know why, but it does seem to.
I've heard things like that too. That's why I'm interested in it. But a lot of people have this question of whether a nerve problem causes their UTI symptoms, or if the UTI caused the nerve problem. Is there a way to differentiate that, or does it matter? Do you just have to address both anyway?
I think that if you don't have any bacteria in the bladder and you do a cystoscopy and you look inside the bladder and it looks normal, then I'm going to assume it's the nerve problem causing the, I mean, if there's a problem in the bladder, it should be apparent.
Yeah.
The bladder has a mucosa you can see with a scope, and if it looks normal, then it's normal. And if you can't grow bacteria or get DNA of bacteria in the bladder, there's no infection. So at that point, it's definitely the nerve causing the bladder symptoms. And there's definitely a subset of people that have, quote, interstitial cystitis when I think they have pudendal neuralgia.
Yeah, I've been wondering the same. And the same with Vulvodynia and urethral syndrome. There seems to be theories
Absolutely.
around that.
Oh, I think those things are often pudendal neuralgia. Yeah.
Which doesn't leave people with a lot of options, it sounds like, for treatment. Is there a long-term hope for people that have those kinds of issues?
Well, yeah, to some extent. Nobody is the master of this. Like, there's not like some Svengali that has the answer to all this. There are people that claim they do, but I don't. I think you will find plenty of people that have had treatment from this expert or that who had failure from whatever treatment they recommended. So there's doing nerve blocks, there's doing local anesthetics, there's doing steroid injections, there's doing Botox injections. Physical therapy, I think, is really important. Some people have really just tight pelvic floor, and the nerve does traverse through part of the obturator internus muscle. So if that muscle is in spasm, it can compress the nerve. So if we can get that muscle to relax, that can lead to healing of the nerve over time. And we can put Botox in the muscle also. And then there are nerve decompression surgeries also. And so pudendal nerve decompression surgery is a surgery where basically we, by a couple of different approaches, but you basically sever the sacrospinous ligament and remove that ligament, which now you have this sandwich of these ligaments where the nerve's going through. Well, now you just remove the top off of it. So now the nerve is just loose in there. And, hopefully if the nerve's truly compressed and you do that, then you give the nerve an opportunity to heal. But again, I say that 6 to 12 to 24 months, like it's not something that's work overnight. And it's extraordinary. My experience is that it's very painful for patients when you do the surgery. It's quite painful. I mean, you're basically creating a grade 3 sprain in your butt. Like if you've ever had a horrible ankle sprain where you totally tore your ligaments in your ankle, it's extraordinarily painful.
It sounds like it.
You're doing that surgically, so you're literally severing a ligament. So that's a grade 3 sprain. And the problem with the surgery is not that, like, the documented success rate of these surgeries is about 50%.
Okay.
But half people get better and half people don't. I don't think that it works half the time. I think that it works 100% of the time in half the people. And the distinction of that is that 50% of the people didn't have the problem you thought they had.
Yeah, that's another question. How can you test for this? You said the nerve blocks can help because it can help identify the location of the problem, I suppose.
I don't know if it helps or not, because if I block the root of the pudendal nerve, anywhere along there is going to get blocked, because it's like, well, if I stop the traffic and the cars are backed up for miles, well, I don't know where the problem was. So like, I've stopped it in one place.
Yeah.
And it's like, if you block it very distally and then you're getting pain, I guess you could infer something from that, but there really isn't. The local anesthetic spreads out. I don't think it's possible to block the nerve in one location. I think that the anesthetic is going to get absorbed into the nerve. It's going to translocate all the way up the nerve. Okay. So I think you're going to block the whole nerve. Okay. Now, part of this, quote, Nantes criteria for pudendal neuralgia is that if you do a block, they should have relief of their pain. really all that means is that the pain is coming through the pudendal nerve. It doesn't necessarily mean why is the pudendal nerve inflamed. Or even if I were to block your pudendal nerve and then I take a needle and poke you in the vulva, you won't feel it. But that's just anesthesia.
Yeah.
Like that's not saying that you have pudendal neuralgia.
Right.
I mean, we literally anesthetize the area that I'm poking.
Yeah.
And so it is difficult to say that just because the pain goes away from a block that you have quote pudendal neuralgia. All it really says is that your pain is traveling through the pudendal nerve. It doesn't say that the nerve is dysfunctional, in my opinion.
Yeah, that makes sense.
And so now you have to put together, like, when did the pain start? Did it start right after a surgery? Did it start after a birth injury? Did it start from a bad fall? You know, if there's like some moment in time where the pain started, then I think that you're far more likely to have success with surgery because something happened. Like you got a hematoma around the nerve, you got a suture through the nerve root at a surgery, like something happened. When it just developed over a long period of time, I think it's harder to imagine like what you're going to do surgically, unless they're a bicyclist or a horseback rider or something, and they clearly have just been banging on the nerve forever. And now, if you unroof the nerve and like decompress it, we're going to give it a better chance to heal. But to some extent, you could also say, well, just stop riding a bike and stop riding a horse, and you're probably going to give it a chance to heal also. The most important, I think the single most important thing you can do in pudendal neuralgia as a patient is stop doing the things that make it hurt. I think to push through the pain is a terrible idea because the nerve is getting injured. It's hurting because you're chronically injuring the nerve. And so if it hurts when you sit, don't sit. And that sounds kind of terrible, or at least sit on a cushion or something. Like when you're doing something that is making it hurt, then you're injuring the nerve. And so you're declining to let it heal. I'm not blaming the person, but I just think that you're doing the wrong thing if you want it to get better. And
I did get a few questions around this because some people have symptoms after sex. They can't tell if it's to do with infection or if it's a nerve problem. Is that the same advice then? Just don't do it? It's not very realistic for long-term abstinence.
I don't think in that case they're injuring it having sex. I think that the sensory issues, they're having sensory issues in the vagina that are caused by their pudendal nerve pain, and that they're perceiving that because of that. I don't think they're injuring it having sex. Most likely. But I think that if it hurts when you sit, you probably shouldn't sit for a long time. If it hurts when you ride a bike, don't ride a bike. Which is tough for people to hear if they like to ride a bike, right? I mean, but you know, the stuff I do, pudendal nerve decompression surgeries, it's a difficult surgery to recover from. And as a doctor, it's difficult to decide when you want to do it. Because what I know is that if we just do that surgery on everybody that meets certain criteria where they have pudendal neuralgia, they get better when they get a block, they meet other kind of you do some other things and it doesn't work. Okay, let's try pudendal nerve decompression surgery. It's going to work like half the time. And in the people, it's going to hurt everybody. It's very painful. So for half the people, it's going to make them no better or maybe worse. And for half the people, it's going to help them over time. So as a doctor, it's kind of hard to like recommend that.
Sounds like it.
The good thing is in my practice, we do it laparoscopically. So I think that a lot of the morbidity from that surgery comes from the approach, which is that classically that surgery is done with a patient in the prone position. They're lying on their front, and you cut through their butt basically to get to the pudendal nerve. And you actually have to sever the sacrotuberous ligament to reach the sacrospinous ligament, which is crazy because there's nothing wrong. You're literally causing two ligament sprains instead of one, and one of them is just associated with the approach. It's not even what you're trying to do. So you can reach that same location laparoscopically. It's a very deep, dark hole that not a lot of people understand how to reach, but I do, and it's part of neuropelviology, kind of learn that. So I think that the laparoscopic approach makes a lot more sense because it's a lot less morbid. So at least we're not creating this permanent scar in your buttocks that's going to hurt forever or for a long time, and you can't sit for months because someone has basically cut right into your bottom. No. you know, there's definitely people that I've operated on for Pudendal Neuralgia that a year later they say, I'm definitely better than I was before surgery. They're not 100% better. Like, I've never seen anybody get 100% better, but I've had people who at 6 months were not better, who at a year said, yeah, I'm a lot better. And I'm definitely able to do things I wasn't able to do before surgery, which is, you know, that's success. Unfortunately, people do not seem, in any kind of short time frame, people don't seem to ever say I'm completely gone.
Yeah.
But that may happen over years, many years.
Okay.
And I think that's the case over all kind of nerve injuries. You have to have almost like a geologic time frame over how long it's going to take this stuff to heal. And you have to have a lot of faith that it's going to happen eventually, both as a person and as a doctor. Because as a doctor, when you tell someone it's going to get better in a year, you're kind of like, am I blowing smoke here? Is this even true?
Yeah,
Nope.
it's a long time.
You know, so yeah, that's kind of the progression of things you can do for pudendal neuralgia. I think physical therapy is really important too. If there is pelvic floor spasm. If there's not pelvic floor spasm, then I don't think it's going to help.
Do you refer patients to specific therapists in that case, or is that something they have to do on their own to find someone?
I refer them. I mean, at least in my community, I kind of know 5 or 6 really good people, so I try to send them to someone that's sort of near where they live. And the most important thing to me is a physical therapist that is knowledgeable but also communicative, so that I can have a conversation with usually a woman, with her, and that we can have a discussion about what are they perceiving, what are we perceiving, because I prefer that kind of relationship with the physical therapist rather than just like sending them out into the ether and I don't hear back from them. So you gotta, you know, so to me, that's usually a physical therapist that's in a private practice that kind of runs their own business rather than one that works for some hospital machine.